Hey everybody. Today we're going to finish up chapter 20 and we're going to be discussing the rest of the information about blood vessels. So let's get in here and let's start with our next group of information after we left talking about veins in the last recording and how they were kind of reservoirs of blood in our body. Now we're going to start talking about capillary exchange. Okay. Capillary exchange takes place whenever we reach a capillary. We're going to be moving fluid and solutes through the capillary and into the tissue, out of the bloodstream and into the tissue. Call this bulk flow. Okay, so don't worry about that vesicular transport on that previous page. I want us to focus on this concept, bulk flow. Bulk flow means that what we're doing at a capillary is truly osmosis, but in the process of moving water, we're also going to accomplish diffusion. We're also going to move solutes. And so as a result, whenever we talk about bulk flow, this is truly what happens at a capillary. Once we reach a capillary, we're going to end up diffusing. And we're going to diffuse the solutes that that cell needs, that those tissues need to survive. And then we're going to diffuse the waste back out of the tissues and into the bloodstream. But we can't just send particles across a membrane, across these cells, these capillaries. What we have to do is we have to move them dissolved inside of water. So at a capillary, we will undergo diffusion, right? So we will see diffusion at a capillary. And diffusion is simply, if you've forgotten, it's just high to low movement of concentrations. And again, osmosis is simply just high to low movement of water. And so the key is we're going to have to have two different forces in order to accomplish exchange and flow at a capillary. We're going to need two different pressures. We're going to have hydrostatic pressure, and then we're going to have something that they like to call colloid pressure, but I want us to start referring to this as osmotic pressure because this is the pressure due to water, and that makes a little bit more sense. First off, let's take a little bit of information about each of these. So bulk flow, again, we're going to be moving things out of a capillary, good things, giving it to the cells in the tissues. We're going to be taking their waste and bringing it back into the bloodstream so we can take it to wherever we need to get rid of that waste. We refer to those two movements as filtration and reabsorption. Filtration is the process of moving things out of the bloodstream and into the tissues. Usually we're going to do filtration with the good stuff, right? Put that in quotes, good stuff. Things that the cells need, oxygen, nutrients, hormones, the things that they need to survive are going to be brought into the tissues through the process of filtration. Out of capillary into tissue equals filtration. The opposite is called reabsorption. To take it from the tissue and bring it back into the capillary, back into the bloodstream, is called reabsorption. And so here we're going to reabsorb the bad stuff, the waste products, the CO2. So reabsorption is going to take place closer to the end of the capillary, while filtration is going to take place closer to the beginning of the capillary. And now we just mentioned those two pressures, and let's delve into those two pressures and see why they create this situation. The first pressure is called hydrostatic pressure. I want you to understand hydrostatic pressure is the pressure due to compressing a fluid. When you compress a fluid, you create this type of pressure, and this type of pressure causes movement. It causes the fluid to move. So we squeeze on it, it creates this pressure, and the fluid starts to move. Hydrostatic pressure is blood pressure. Okay, we don't really have a hydrostatic pressure in the tissues in the interstitial fluid. And remember, interstitial fluid is just the fluid in a tissue. And so we don't have a pump, right? So the heart creates hydrostatic pressure, and that is our blood pressure. So a good way to think about hydrostatic pressure and what it's going to do at a capillary is if you had a garden hose and you turn that garden hose on, but you still had like the little spray handle on, but you didn't have it spraying. So the pressure builds up in that hose. If you go with a knife and you start poking holes in it, well, the pressure that's built up in there, the hydrostatic pressure, is going to start pushing the water out of the garden hose, right? You've never seen the garden hose suck water in, right? If it's got a hole in it, it pushes it out. So this is the exact same thing that happens. That's hydrostatic pressure. This is the exact same thing that happens in our capillaries. Our capillaries are the garden hose, and they've got these holes in it. So I definitely want you to know hydrostatic pressure is what drives filtration, right? The movement of fluid and solutes out of the blood and into the tissues. Now, hydrostatic pressure, blood pressure, is going to drop the entire way through a capillary. We've kind of mentioned this already. Blood flows from high pressure to low pressure. And so as a result, blood is going to have the highest pressure at the heart, and then it's going to drop through the arteries, it's going to drop through the capillaries, and it's going to continue to drop through the veins until it gets back to the heart. So we have to have the highest pressure at the heart where it's pumping, and the lowest pressure at the heart where it's coming back into the heart. And so this hydrostatic pressure, you need to understand, and you need to definitely take a note that this is going to drop as you go through the capillary. Now, this is kind of a variable pressure, right? It's going to change as we go through. We're going to start out somewhere around 35 millimeters of mercury, and we're going to drop down to somewhere around 18 millimeters of mercury or so. And so in that process of dropping, we are able to push more at the beginning of the capillary and less at the end of the capillary. And if you remember, I mentioned just a second ago, filtration tends to take place towards the beginning of the capillary, the arterial end, because the hydrostatic pressure is greater than our osmotic pressure. Colloid osmotic pressure, I prefer to just refer to it as osmotic pressure. Osmotic pressure, though, it's telling you right here what it is due to. It is due to the proteins in the fluid. Well, we know that we've got a lot of plasma proteins, especially those albumins, right? Remember, we learned that albumins set up osmotic pressure. They set up osmosis and exchange at capillaries, and here's how they do that. The fluid that has more colloid, that has more protein, has less water, and so it creates a pull towards where there's more protein. Just like water follows salt, we're going to go from a high water to a low water. So if we have more proteins in the blood, then we have a lower water concentration in the blood. So I definitely want you to understand osmotic pressure, it's due to the pull of water due to the presence of proteins in the blood. And what it does is this encourages reabsorption because there's lower water value in the blood because there's more proteins. That means that there's higher water in the tissue, higher osmotic pressure. And so as a result, we're going to pull the fluid out of the tissue and into the bloodstream. And so again, this is how we're going to reabsorb the fluids back into the blood with the waste products, right? Now, this is a constant value. As blood flows through the capillaries, it doesn't change the amount of albumins or proteins that's in the blood as it flows through that capillary. So I want you to know that osmotic pressure is constant. The whole deal is if we have more hydrostatic pressure than we have osmotic pressure, then we create filtration. But if we have more osmotic pressure than we have hydrostatic pressure, we create reabsorption. Now again, if colloid osmotic pressure, if the osmotic pressure is somewhere around 25, let's just make it a random number, 25, then when the hydrostatic pressure drops from 35 down to 18 or so, when the hydrostatic pressure is 35 down to 25, we're going to get filtration in that capillary. More hydrostatic than osmotic equals filtration. But then once that hydrostatic drops below 25, now the osmotic pressure is greater. And because now the osmotic pressure is greater than the hydrostatic pressure, towards the end of the capillary, where it's dropped below that 25 down to the 18, that's where we're going to create reabsorption. Okay, now we can also kind of think about it a different way. We can calculate net filtration pressure. Net filtration pressure is simply just the net hydrostatic pressure minus the net colloid osmotic pressure, minus the osmotic pressure. Now, if we go back, I pointed out earlier that the interstitial fluid hydrostatic pressure, the pressure due to compression in the tissue, is zero practically because there's no pump like the heart in our tissues. But here, this colloid osmotic pressure, it's relatively low as well. So we almost don't have to worry about the colloid osmotic pressure in the tissues. So really, what it becomes is net filtration pressure is really hydrostatic pressure, or the blood hydrostatic pressure, minus the blood colloid osmotic pressure. So basically, it's just filtration pressure is hydrostatic minus osmotic. Okay. Now, if we have a positive value here for this filtration, if filtration pressure is positive, that means hydrostatic is greater than osmotic. So you can give yourself a note. If filtration pressure or net filtration pressure is positive, we get filtration. But if net filtration pressure is negative, then we're going to create reabsorption, right, in that capillary. And again, filtration moves fluid out and into the cells, into the tissues with good stuff, and reabsorption brings their waste and bad stuff back out and into the bloodstream. Here's an example. At the arterial end, we got high hydrostatic and our osmotic is constant, right? If we actually take away the interstitial osmotic, and that's what they're doing here, taking the blood osmotic and the interstitial osmotic and taking it away, and then we do the same thing with the blood hydrostatic and the interstitial hydrostatic, which is practically zero, then we can actually calculate our net filtration pressure. So here towards the arterial end, we've got a plus value, plus 14, so that means we're going to create filtration towards the arterial end. But then once we get to the venous end, then we see that blood pressure dropping. And again, the blood pressure drops, but the osmotic pressure stays the same. So now we've got more osmotic than hydrostatic, and our net filtration pressure is negative. So as a result, now we're going to create reabsorption. We're going to regain the waste back into the bloodstream so we can get rid of it. Now, here's a great image that's going to demonstrate that. You should find this image in your textbook and kind of take a look at it. Here it's showing you 35, and they say down to 16, okay, is the lowest hydrostatic that they go. I said 18. So 35 down to 16 is what they say. They put the osmotic pressure at 21, and I put it at 25. Okay, the numbers are a little different, and everybody's pressures are a little different, obviously depending on your blood pressure too. And so these numbers can be different. The big point is when hydrostatic is greater than osmotic, then we're going to get filtration. We move things out, bulk flow out of the capillary and into the tissue. But whenever it's lower, when that hydrostatic is lower than the osmotic pressure, we're going to start to pull things back in. Now, I want you to notice that we have more space, more time, 35 down to 21 compared to 21 down to 16. Right? So we've got more area where we've got greater hydrostatic than we have area where we have greater osmotic. Now what that's going to create, see this with the arrows, we're going to end up filtering more fluid that we're going to reabsorb. And this is important, okay? 15% of the fluid that is filtered is not reabsorbed, okay? This fluid is trapped in the tissues. Now, if we never drain this fluid, then we would create the situation that's called edema, E-D-E-M-A. Edema, that's accumulation of fluid in the body tissue. If you've ever seen a pregnant lady's feet, towards the third trimester, she's retaining a lot of fluid. So my wife told me that I had to rub her feet every day. That was a prescription the doctor said. I think she's lying, but who knows? So I did it. But the whole point is that every day when she was pregnant, then I would rub her feet because that made her happy, and her feet hurt. And if you've had kids, I'm sure you can relate. And so when I'd rub her feet, though, her feet like memory foam mattresses, right? I would squeeze on them, and it wouldn't really spring back. It would keep the handprint that I would squeeze on her foot, and that's that edema that we're talking about. That's that fluid accumulation. Now, the whole key is this 15% doesn't usually stay in the tissues, though. We don't all walk around with edema. We don't all walk around looking like these memory foam mattresses. So we have to regain this 15%. I want you to know this is the beginning of the lymphatic system. When this 15% of the tissue, 15% of the fluid is drained away from the tissue in a different drainage system with lymph vessels, then this 15% is what becomes lymph. So we just created lymph. Now, lymph is the fluid that's been in tissue. So it's chock full of all kinds of things that's in that tissue. So as we drain that tissue, we can expose whatever's in that tissue to the immune system, to a lymph node, for example, and there we can trigger an immune response. And that's many times how we trigger immune response is through the lymph system. Now, let's talk real quick about local blood flow. That's really kind of the hardest topic that we're going to cover this chapter, it feels like, is this whole process of capillary exchange. Now, we're finished talking about capillary exchange. We're moving on to local blood flow. Now, what we're talking about is how do we deliver blood to very specific tissues? How do we give blood to the more active tissues and take the blood away from the less active tissues? Well, here is what really determines how much blood reaches a tissue. So go ahead and jot these three things down. First off, it's the vascularity, how many vessels it has. The second thing, it says altering blood flow. Give yourself a note: vasoconstriction and vasodilation. And I actually put a big star beside that one on both sides, right? This is going to be the main way that we can actually control that local blood flow, is opening and closing blood vessels, okay? The third way is the total overall blood flow out of the heart. And we learned that already as cardiac output, right? So let's dive into this and take a look real quick. The degree, again, the first thing was vascularity. How much blood vessels does it have? Well, we can't give it more blood if it doesn't have more blood vessels, right? So some things are more vascular. Some things have more blood vessels: your brain, your muscles, your heart, your liver. These things have a lot of vessels. But some things have little to no vascularity. Tendons, ligaments, don't forget cartilage and epithelium. They have no blood vessels at all. So if you don't have blood vessels, you can't have a lot of blood. Now, if you become more active, then you are going to start to form new blood vessels. This process is called angiogenesis. Angiogenesis is the formation of new blood vessels, and it's simply because you've started to put more strain on the body. It needs more oxygen to the cells. And so as a result, then we're going to start creating new blood vessels. And the way I like to think about this is the original blood vessels may have been the main street on the on downtown, right? But there's also alleyways behind some of the streets, behind some of these buildings, that service the backside of these businesses. And so it's the same kind of concept. We've already got our main roads, but with angiogenesis, we can build some new alleyways. And what we can do now is give them a little extra blood to make sure that they get everything that they need, right? So again, it takes weeks to months to do this, and it's in response to aerobic training or possibly weight gain. And you could lose blood vessels as well. So these blood vessels could regress if you become sedentary, you lose that activity, or if you lose that weight, which is a good thing. More weight means more blood vessels, which means more blood, which means more workload on the heart. So it's definitely a good thing in this aspect to experience regression. Again, the second way that we can control local blood flow, or that local blood flow is accomplished, is through regulation. Local regulation refers to vasoconstriction and vasodilation. Another term for this is autoregulation. What this really is, again, let's use that word local. We've got vasoconstriction and vasodilation, but it's on the smallest levels. It's not systemic. It's not spread wide across the body or a region of the body. Instead, it's just in the specific area where that blood is needed, right? So it's local. And again, you don't have to worry about vasoactive chemicals, but certain chemicals make blood vessels open or close. A vasodilator is is the chemical that's going to open a blood vessel, and a vasoconstrictor is a chemical that's going to cause that blood vessel to close. Now let's think about it. If we open the vessel, we're going to increase flow. And if we close the vessel, we're going to decrease flow. So what we tend to do is a lot of local regulation. As some tissues become more active, we vasodilate towards those tissues, and we decide which tissues are less active, and we vasoconstrict towards those tissues. So we're lessening the blood to the less active and increasing the blood to the more active so that they can do their thing. Again, like I said, this is a form of auto-regulation, this local regulation, and this is always the first thing that kicks in. Now, anytime we're talking cardiovascular or respiratory, you always need to know that there's three triggers that will almost always trigger either of these systems. The first thing are going to be oxygen and CO2, right? Because that's really what links these two, is the gases. But the other thing that's really going to trigger this is this right here, our H plus pH. So don't ever forget the three things that can change blood flow and also respiratory flow, respiratory rates, is going to be O2 levels, CO levels, and pH levels. Those are the main things that really trigger these changes in our CVS and our respiratory system. Again, the last thing was total blood flow, and again, this is equal to cardiac output. So if all tissues become more active at once, like we're exercising, then we need to increase the overall blood flow. And that's what cardiac output is blood per minute out of the heart. So if we increase that stroke volume and that heart rate, then we're going to increase that cardiac output and get more blood flow to all tissues overall. Okay, let's talk about blood pressure real quick. Blood pressure, again, this is a form of a hydrostatic pressure. We compress a fluid and it creates a movement to an area of lower pressure. So we're kind of squeezing it from high to low pressure. And so that's what the heart does. I definitely want you to understand that the heart is what creates our blood pressure. Now, blood pressure, as we've already mentioned, it is a gradient. It is going to drop. It's highest in the arteries and it's lowest in the veins. If it continue to drop all the way through the body, then we're not going to get blood coming back to the heart, and that's definitely not what we need. Let's look at this arterial blood pressure real quick. Arterial blood pressure is pulsatile, so that means that it goes up and it goes down, and this is due to the heart. The arteries are closest to the heart, and so this blood pressure is going to go when the heart pumps, and it's going to go down when the heart relaxes. The high pressure is called systolic pressure. Systolic pressure is the pressure during the contraction, and we're going to learn that systole is the term for contraction of the heart. So this is when we have our highest pressure. Systolic pressure is the highest pressure during contraction. Diastolic pressure is the lowest pressure. This is basically the lowest pressure that's in the arteries that keeps the blood flowing in between beats, right? Blood doesn't stop just because you have a up and then a relax. It doesn't completely relax. There's still pressure. And so blood is still flowing all the time through your vessels. Now, this, if you haven't noticed it, again, diastolic is during diastole, and diastole is a term for the relaxation phase of these chambers. And so if you haven't noticed, systolic over diastolic is your blood pressure, right? So usually you get this read as the high over the low, and that tells us how hard is your heart working, right? We don't want to have too much workload on the heart. Now, to find out how much total pressure is involved in that actual process, we can calculate pulse pressure. Pulse pressure is systolic minus diastolic. So it's really easy. Take the low number away from the high number, and basically you come up with how much pressure was there in the system overall. So here, 120 over 80, the pulse pressure is 40. Now, again, this can change based on exercise, based on age, disease, whatever. But the pulse is actually the results of this pressure, the high and low, the up and down. So this is the throbbing sensation that's associated with that pulse pressure. And we can compress those arteries against a bone and kind of detect that pulse pressure. We need to understand mean arterial pressure, and you need to be able to calculate one of these problems on the test. Mean arterial pressure is a way to discuss blood pressure, arterial pressure, without having two numbers. A lot of times this is clinically used and used much more than anywhere else. When we look at this, we see that the mean arterial pressure is kind of an average, but we know in math, mean and average are slightly different. So we can't just add the two and divide by 2. That would be a whole lot easier, but that's not how it works. Mean arterial pressure is equal to the diastolic pressure, right, the low number, plus 1/3 of the pulse pressure. So in other words, you take the pulse pressure, the difference between systolic and diastolic, and you divide it by 3, and then you add that number to the diastolic or the low pressure, right? So here's an example, 120 over 80. Let's start over here. The pulse pressure would be 40, and if we divided 40 by 3, we're going to get 13.3. And if we add 13.3 to the diastolic, then we're going to get 93.3, and they just dropped the 0.3. So 93 here, okay? So if your MAP is less than 60, then you don't have a good blood flow, right? So this is clinically used more often than just discussed, right? So make sure that you're able to do a simple problem like that. Again, in the capillaries, blood pressure is going to drop. Here, let's get some numbers. I want you to know these numbers. First off, in the arterial, blood pressure ranges from a MAP of around 100 down to around 35 millimeters of mercury, and we see that unit right there, mmHg. For my class, I want you to know that capillaries average somewhere around 35 down to 18, and then veins average somewhere from 18 down to almost zero. You can't reach zero or it would stop, and so it's almost zero. So veins, the blood pressure that we have in the veins, we have an issue. We have an issue with venous return. Venous return is blood coming back to the heart. And so venous return is an issue because the blood pressure is really low. The blood pressure is really low, and especially, for example, if you're standing in your legs, gravity wants to keep the blood towards your feet, but pressure wants to push it up. So we need some help here. And so we're going to need some different things that's going to help that blood pressure to get the blood back up to the heart. So I kind of like to add something else first. I like to add number one, valves. So let's list valves before we hit skeletal muscle pump. Valves are super important, right? The valves, they help compartmentalize the vein. And then that way you can squeeze that compartment and push the blood up above the next valve, and we're pumping uphill that way. It's a form of pumping uphill. So really it's the first two, valves and the skeletal muscles, that provide this pumping feature. And so valves compartmentalize, and then the muscles of the leg, for example, will squeeze on those veins and push the blood up above the next valve, and then the valve prevents backflow. And so now the blood is moving uphill simply because of compressions. For example, your gastrocnemius muscles, and here is a vein. So we've got it compartmentalized. We squeeze on this compartment, blood goes up, doesn't go down, and now we're kind of creating this flow, right? The other thing that helps to bring blood back to the heart, that assists vein return, is called the respiratory pump. So this is kind of a third thing. If we had valves at 1, and then skeletal muscle pump at 2, and then respiratory pump at 3, then the respiratory pump, what I want you to understand is that pressure changes during breathing. Pressure changes during breathing create low enough pressure in your cavities, your body cavities, to help pull the blood uphill. Okay, so as we breathe, we're going to change the pressure in the thoracic cavity, and that's going to affect the pressure in the abdominal cavity. And so whenever we breathe, inspiration, we're going to create this compression down here in the abdominal cavity, because we've got lower pressure up here in this cavity, we've got higher pressure down here, so it squeezes on the inferior vena cava and helps to push that blood up to the heart. So the actions of breathing help to move blood back to the heart. Again, somewhere from 100 down to 0 are the numbers that I want you to know. I don't want you to know this 93 kind of here, right? And it can't be 0. It has to be a little bit above positive, or else blood won't flow back to the heart, really. Okay. Here we see some information about checking blood pressure. And so I do want you to be familiar, and we'll talk about this in just a second as well, that we're going to use the sphygmomanometer, and that's the blood pressure cuff, and we're going to use a stethoscope. We're going to inflate the cuff to the point where we have enough pressure to cut off blood flow. We're slowly going to let the blood flow back, and we're going to use the stethoscope to listen for that blood flow. When we hear the first sounds, that means that that's the highest pressure pushing blood through that vessel. It's going to be our systolic. And then when we hear the last sound, that's when blood starts to flow freely at the lowest pressure. And so that's going to be our diastolic pressure. Even whenever you're taking blood pressure, you can even look at the needle, and it will kind of bounce whenever you hit the systolic, and it will stop bouncing when you hit diastolic. Okay. Here's a view of pressure to show you how pressure in the arteries is pulsatile, so it goes up and down. I definitely want you to understand that the elastic in those arteries take the stretch, and then they recoil in between beats, and that keeps that blood flowing the entire time through the system. Once we reach the capillaries, though, we lose that pulsatile. We've handled the ups and downs in the arteries with the elastic and tractability, and now in the capillaries and the veins, we don't have to worry about it. So we don't really see smooth muscle, and we don't really see elastic in capillaries or veins because of that. Detecting a pulse, as I mentioned, the pulse we can detect by compressing a blood vessel against a solid surface. Usually it's a bone. So here, for example, we see several different pulse points on this individual. Usually we check it at the radial artery, and usually we check blood pressure at the brachial artery, right? And so there's other places you can see all these different regions that you could also detect your pulse. Again, here is that term sphygmomanometer. As I've already mentioned, this is the cuff that's used in measuring blood pressure, and I went over that process on that image. So if you need a little bit more, go back and re-listen to that whenever I cover it on that, when I covered it on that picture. Let's talk about circulatory shock real quick before we go into our next section. Circulatory shock means that you don't have enough blood flow to your tissues. Now, this could be due, and I want you to understand that circulatory shock many times is defined as a loss or misappropriation of 20 to 30% or more of the blood volume. So you either are bleeding out, you're losing blood, like hemorrhaging or dehydrating, or you have not enough blood flow to the right organs, to the right regions of the body. This is due to, and I want you to understand this is sometimes due to what we call extensive peripheral vasodilation. So add the term peripheral in there, extensive peripheral vasodilation. That means too much opening of blood vessels in the skin. So I definitely want you to know that. Circulatory shock can happen whenever we open too many blood vessels in a region that doesn't need the blood, and we take the blood away from the organs that actually need it. This is what happens, for example, in anaphylactic shock. That bee sting, as an example, causes extensive peripheral vasodilation in the skin, and you start to get hives, you start to get red skin, and now too much blood is in your skin and not enough blood is for your brain and your liver and your heart and your lungs. So now you're going to start to slowly suffocate and die. If you don't change that situation, okay, epinephrine causes vasodilation. So that's what the EpiPen does, is the EpiPen it causes vasoconstriction. I apologize, I said that wrong. The epinephrine pen causes vasoconstriction, and it counteracts the dilation that could eventually kill you because you don't have enough blood to the brain and the heart. Now, let's move on to talk about resistance. And sometimes this is referred to as peripheral resistance, total peripheral resistance. What things slow the blood down as it's flowing? The first thing is viscosity. Okay, so the thickness of the blood. If blood is thicker, then it's going to be harder to pump. So thicker blood, more dehydration creates more resistance, and that can eventually um, create problems. Now we need to understand, actually, let me back up just a second. In order to get blood flow, I want you to understand, in order to get blood flow, pressure must be greater than resistance. If we don't have more pressure than we have resistance, then we're not going to get blood flowing in the proper location, in the proper way. And so P greater than R equals flow, right? So then what are the forms of this resistance? Again, thickness, we already mentioned. Too thick is a problem. Let's talk about vessel resistance. And let's include both of these. Vessel resistance, the length of the vessel and the lumen size, or the diameter of the vessel. Okay, now length doesn't really change once we become adults unless we experience angiogenesis, right? Then we add length, and that means that we add resistance. So we have to pump a little bit harder. Okay, so this doesn't really change very much, so we're not really going to worry about that. But the lumen size, the diameter, this is what we've been talking about that we can control. Make sure that you understand the vessel diameter or the vessel radius is the most important form of resistance, because this is the resistance we can control to create blood flow. Vasoconstriction and vasodilation can control blood flow by adjusting the size of the lumen. And so opening and closing is very important. Now, the third thing that they don't list that I would add is the term turbulence, just like in an airplane. Turbulence. Add that and give yourself the note. Odd flows, right? Uneven, odd flow in the blood. If you have some blockages or something bulging into the bloodstream, like an atheroma, right, atherosclerosis, then that can start to create turbulence. And too much turbulence can bring a plane out of the sky, right? Same kind of concept. Too much turbulence can slow the blood flow down to the point where you don't get the flow. Okay, so as we mentioned, Viscosity is important. The thickness, blood's 5 times thicker than water. And again, as it gets thicker, it becomes harder to pump. Vessel length remains constant during adulthood, so we're not too concerned about this, but the longer the vessel, the more resistance. The vessel radius is the major way that resistance is regulated and controlled, right? So vasoconstriction and vasodilation is very important to control flow. You don't have to know the exact number, but I want you to write down the fact. A small change in vessel radius creates a big change in resistance. Okay, it's to the 4th power. So it's 16 times, right? So small changes in radius create big changes in resistance. Okay, so just opening and closing those vessels a little bit can really make a big deal. Now, we've already talked about this a little bit. We've talked about the blood pressure gradient and how blood flows downhill. So I'm not too concerned about this slide. Again, resistance, too much resistance means that we have less blood flow. So we have to keep the pressure greater than the resistance in order to maintain that flow. Here's a little rating some of those factors. Now, again, let's talk a little bit about regulation of blood pressure and blood flow. So here we're going to mention a few things. Of course, anytime we talk regulation of blood pressure or blood flow, anytime we talk regulation, we're usually talking nervous and endocrine system, right? So let's discuss the two ways, the nervous and the endocrine ways, that we can kind of change this blood pressure and change the blood flow. First off, I want you to be familiar that auto regulation, that local regulation that we've already talked about, is super important in this process. That's going to take place first, okay? So we're going to try to use that process first, but then we're going to kick in with a lot of autonomic reflexes, okay? So we're going to use a lot of autonomic reflexes. Those are the things housed in that medulla oblongata, right? So go watch The Waterboy if you haven't in a while. And so we're going to make sure that we control on the smallest levels first, but then we can start controlling on bigger levels. In the nervous regulation, right now we are talking neural regulation or nervous component. We're going to have in the brain, in that medulla oblongata, something referred to as the cardiovascular centers. We're going to have two of them. We're going to have one that's the cardiac center. Cardiac is going to help change the heart. And you can go ahead and learn that the cardiac center is going to speed up or slow down the heart. Okay, so it adjusts heart rate. And then the vasomotor center. This is going to adjust what's happening at the vessels. So the vasomotor center adjusts the vasoconstriction and vasodilation. Okay, so let's mention these just a little bit before we start to wrap this presentation up. Again, the cardiac center, I do want you to know that there's a cardio-acceleratory center and a cardio-inhibitory center. Okay. Now, as we mentioned, this is an autonomic type of response, and so we're going to have sympathetic and parasympathetic involved. As you can remember, hopefully, sympathetic is more stimulatory. So the sympathetic division is going to be responsible for cardio-acceleratory. And the parasympathetic is more rest and digest. And so this is the cardio inhibitory center. Okay. And so parasympathetic triggers inhibition, sympathetic triggers acceleration. That's the way to think about it. Besides these guys, we can use pressure, baroreceptors. So we can detect the stretch in the vessel, and that stretch can help us to regulate then the blood pressure. If we have too much stretch, we have too much pressure. So that means we may need to adjust the blood volume overall. Again, these are all reflexes. So don't forget, these are all reflexes. The baroreceptors are triggered by pressure changes. And chemoreceptors are triggered by changes in chemicals. Again, don't forget that the chemoreceptors are always going to be triggered by CO2, oxygen, and pH. Be triggered by something else, but let's keep it at those always to make sure that we know these are the important ones that we're always regulating and we're always monitoring that can trigger a change in this whole process. Besides those two, there's also some regions outside of the medulla oblongata, up in the upper regions of the brain, higher brain centers. So that's the reason we call them higher brain. It's not in the medulla oblongata. The hypothalamus can help control cardiac output. It can help control adrenaline release, right? And as a result, it can help control part of that sympathetic reaction. And it can also help control some resistance by controlling vasoconstriction. Your limbic system can also alter your blood pressure due to your emotion. Remember, limbic system in the nervous system was our emotional and our motivational system. So these things can have an effect on your blood pressure as well, your emotions. If you're upset, if you're happy, then these things can matter. Let's switch over and talk about endocrine. Now, whenever we talk about the endocrine response, first off, I want you to realize that there's two main players, right? The two main effectors are ADH and aldosterone. Don't forget that ADH conserves water in the body. We're going to hit it again in just a second on a slide, but it conserves water in the body. Aldosterone conserves salt or sodium in the body. So if we trigger these two, we're going to increase the blood volume. And if we increase the blood volume by retaining water and salt, then we're also going to increase blood pressure. So we're going to find out angiotensin 2, its job is to increase blood pressure. So one of the main things it does is it stimulates both ADH and aldosterone. Then we're going to find out ANP, atrial natriuretic, inhibits both of these. This thing is going to help lower blood volume and lower blood pressure. So there's our four hormones. We got the two main players in the middle, ADH and aldosterone, controlling how much fluid and salt is in the blood, in the body. And then we've got one that's going to stimulate and one that's going to inhibit. And that way we can either keep more or keep less in the body. So let's look at this. Again, aldosterone from the adrenal cortex. This thing helps to absorb sodium especially. So it keeps the salt in. And remember, water follows salt. And aldosterone and ADH almost always work together. So aldosterone keeps the salt in, and antidiuretic hormone ADH from the post-pit, it's going to keep the water in, right? It's going to trigger thirst. It's going to decrease urination. We talked about this in the endocrine chapter. And so ADH is going to keep water in. Again, these two tend to be linked together, and so they can trigger our thirst center and our salty food hunger center kind of thing. Now let's talk about renin. Renin, anytime you see renin, we taught this as well under the endocrine. If you remember, anytime we see renin, we connect it to angiotensin, right? Especially angiotensin 2. That's the actual enzyme. That's the actual hormone enzyme that is going to be used to make the changes in the bloodstream. Angiovessel tensin, right? Here, that's tensinogen. Hold on. Here's our angiotensin 2. Angiotensin 2 is the real enzymes that cause the effects, and what they do is they stimulate aldosterone and ADH. In the process of stimulating those, they decrease the urine at the kidneys, they increase your thirst center, as a result, raising blood volume, and that raises blood pressure. Okay, so again, renin, angiotensin stimulates aldosterone and ADH, while on the other hand, we're going to see that AMP, atrial natriuretic peptide, inhibits both of these. So that's kind of its goal, is that it is released when the heart stretches, right? When the atrium stretches, that means we've got too much blood volume. So we need to decrease the blood volume, we need to increase the urine output, decrease the thirst center, but in the long run, you definitely need to know that AMP inhibits ADH and aldosterone. Now, to end this up, finish this up, we've got the terms hypertension and hypotension, and then we'll be done. Hypertension is high blood pressure. 140/90 is usually what we consider high blood pressure. This can start to damage blood vessels, make atherosclerosis take place more often, thicken the walls, start to cause this arteriosclerosis, and this is a major cause of heart failure. So hypertension, high blood pressure, take care of that high blood pressure. Hypotension is too low. This is not very common. Many times this is due to too much blood pressure medicine. So 90/60 or lower, that's definitely too low. You're going to feel dizzy and faint fatigue, that kind of thing. Sometimes whenever you stand up, you get lightheaded. You don't need to know this for the test, but that's referred to as orthostatic hypotension. When you stand up, it takes your body a little bit longer to regulate, and so you get this lightheadedness and this dizziness. And so, it just happens sometimes, or it could indicate that there's some other problem. All right, so that's it for this chapter. We've finished this up. Don't forget that this chapter is in 2 parts instead of 1 part like usual. So make sure that you're watching both parts of this, and this completes everything for our next test. So make sure that you're getting prepped for that test, you're studying up as well as you can, and you're going to come out and you're going to do really well and get that grade solidified for the rest of the semester. All right, y'all. Hope you have a great afternoon. See ya.